it's a nice segue into, how do our degrees differ? How are they similar? How long did they take? And, what do we do now? And where do we see others with our degrees working in and outside of healthcare?
And we can even add a layer of complexity, because I was going to pharmacy university in France, and I don't want to speak for all of Europe, but I just know the training in France is different from the training in North America. I had a lot of my friends back in the university that wanted to go to Quebec, just because obviously for French language. They were saying that's really difficult because of the strong emphasis on clinical, as opposed to way more scientific background. It's just years and years and years in university in France, where we would spend 5 years at the university with professors that were very interesting, but we were not really doing clinical up until the 5th year, where you finally go into the hospital and you meet with patients and pharmacists, and now you can do PK and PD and apply it to real life, as opposed to just going by the book. So we spent a lot of time, and the feedback that I got from my friends who went to Canada were that in Canada it was much more clinical emphasis, and so it was difficult for them, but that was on the 4th year, so they would go 1 year early compared to everybody else who would go to the hospital on year 5, and just a different way to train. And I know that for myself, I'm going to get my license in the United States. I've looked at how it all goes, and there's definitely way more clinical, which I think is good. Even yesterday we were talking with Alec about the fact that pharmacists get a course for injections. So I looked it up this morning. I was curious. I know that was recent in France, where pharmacists would inject their patients for a vaccine, and that's been optional and but recommended as of 2019. So it's pretty recent that finally you can get a script, bring it to your pharmacist, and get a shot for the flu or whatever. So those are different, and I guess in the United States it's probably more, and in Canada more advanced in that sense.
So what did you learn in pharmacy school? Can you kind of break it down?
Oh, you get a lot of physiology, you get a lot of organic chemistry, you get a lot of even some physics to get started for the first couple of years. And then you go, as years go by, you go more into immunology, cardiology, but this is very theoretical. So you just look at all the drugs that are being used, obviously, with a pharmacokinetics and pharmacodynamics standpoint. But it's just you go by the book, and that's just how it goes. And then you applied pharmacokinetics will be on the 5th year. So you just spend a lot of time looking at the epidemiology, looking at the physiology, some anatomy as well, not as much as the MDs obviously, but yeah, it is a lot of book reading, and that's the way it's trained in France. I don't know how it is in the UK and Germany. I mean, compared to every single country, obviously, but it's not as strong. I mean, again, it's what I've heard and it's what I've seen now, and I'm getting into the process of getting a license. It's just it's different, right? You don't have as much clinical. That's the big thing.
During your 5th year, did you routinely work in an interdisciplinary team, or specifically the pharmacy team? For example, did you round with the residency or medical students?
Twice a week, round with the residents and the head of the unit. So for me, that was infectiology. So we were working specifically with the pharmacist that was there as a resident. So me and her, we were working on specific antibacterial treatments. So just looking at potential resistance to bacteria. And that was our thing, but then we would go to the round table. We wouldn't not really talk too much, but just kind of listen to what the doctors and the head of clinic were talking about. Go out and meet with the patients. There was that. I was doing this, and then I had another semester doing hematology. So I saw a lot of blood work, which is what I'm still doing now with Gillett Health. Saw a lot of blood work, and that was very interesting. So we had some more of a research side of things with just looking at different pathologies, but like applied in real life. And so it took 4 years to get there. Because finally you can actually see real people with, and then you get to meet the researchers, you get to meet the MDs, you get to meet the nurses. So you kind of step out of the pharmacy and pure pharmacy training. There was a lot of biochemistry. There was a lot of that. So we don't go to college and get an undergrad and then go to pharm school. So you kind of get all of that together, and then finally get to go out and do more clinical stuff.
So where do you see, besides clinics, where do you see pharmacists working predominantly? Or what are some common non-traditional roles that you see your classmates or PharmD colleagues in?
There's been, obviously the big part would be just regular pharmacies, like in the United States that would be CVS, Walgreens. You get a lot going to medical affairs. Actually, you get a lot going to quality. You get a lot going to regulatory. You get a lot going to cosmetics. There's a big segue into cosmetics for a lot of us. So the industry part of it is quite important. And then you get, I would say, a minority going to the hospital and clinics. It's just an extra 4 years in France, so you become an intern, and it's quite tough. And I would say only the most motivated and the grade A plus students go into the clinical side of things, so a lot of respect for them. I went into marketing myself because I wanted to kind of segue into business. And so I got an extra year of training for marketing and strategy, which was quite a lot of pharmacists, engineers could actually get in there. So we had a big class of half pharmacists, half engineers, which was interesting. So we got training for medical devices, how to get them on the market, but more from a marketing standpoint. So
I definitely see more pharmacists integrated into the clinic. That's one of the things that I missed about academia is the interdisciplinary team where they have the pharmacist right there and the PhDs as well. With the advent of precision medicine, so precision pharmacokinetics, genomics, you have a background in engineering as well. So you have worn a couple different hats.
Yes. Yeah, so my bachelor's was in biological systems engineering, and my PhD was in regenerative medicine and biomaterial design. So still got to wear the engineering hat, but also interface in a hospital setting, even in some patient-facing research roles. But everybody's PhD is extremely different. I really only know biomedical science and clinical PhD. So, all of my insight is really in the hospital and the research side of things. Obviously, you can get a PhD in just about anything, but there are a lot of similarities, I think, between PhDs and PharmDs in terms of what they go on to do. But our education, is significantly different, where a PhD student generally takes the GRE and matriculates in a certain program, whether it's immunology, in my case it was regenerative medicine, and you spend generally the first 2 years taking didactic classes, and occasionally these are with PA students, PT students, depending on the university, MD students. You see a huge variety of the types of students in your classes, which is really interesting. But generally the first 2 years are didactic, and the education is structured more like an undergrad, where you have a variety of core classes. For us it was macromolecules, physiology, anatomy, medical immunology, cell signaling, and really in the second year is where you start to become more specialized in your education, right? So the saying in around PhDs is you get really, really good. You learn everything about one tiny little subject. And part of that, I think, is by choice. When I was getting my PhD, I didn't want to do that, so I sought extracurriculars in the clinic, and really branched out from a basic research lab, so a basic science research lab, and started, working on the clinical side of things. But so you don't have to fall into that trap if you get a PhD. But that being said, you also, the most significant part of getting a PhD is carrying out primary research. So generally, PhD students have to publish at least one first author publication, but generally the requirements are more than that. So this is, carrying out laboratory or clinical research and publishing it in a peer-reviewed journal, which is no easy task and takes a long time. And generally, at least for PhDs, most of them stay in academia. So the logical, or I guess the general process after graduation is joining a postdoc, which, the equivalent for an MD would be a residency. And, a postdoc generally is anywhere from 2 to 5 years, with the hopes that you become a professor. And I would say that the rest of these PhDs go into industry. And really, this is where the similarities are with the PharmDs. They go into medical affairs as medical science liaisons or medical information specialists. At least in my experience, our medical information team is made up of pharmacists and PhDs. Medical affairs teams generally are made up of PharmDs, PhDs, and MDs or DOs. And you see them, a lot in R&D as well. So there are a lot of opportunities, I think, outside of academia, and generally, my assumption was as I left academia, I would be collaborating significantly less, but that has been the complete opposite. I found, that my day-to-day is consistent engagements with physicians, nurses, nurse practitioners, PAs, PharmDs. So it's interesting to see where my classmates, have kind of ended up. But all of them have stayed in medical research except the select few that are in venture capitalism, or I guess haven't stayed in research but stayed in medicine.
What would be your advice to clinicians? During training, a lot of clinicians, especially medical doctors, worked on a few studies and they have interest in it. But a lot of these individuals are no longer in academia and they're no longer associated with industry. So they're at clinics, hospital-associated clinics, private clinics. How can they get tied in to help regenerate that?
Great question. There are a few ways. The first one that I would tell to that type of provider, and I would also tell to a PhD student, is there are no rules on what you can and can't investigate as long as you're doing it legally, obviously. And you can publish that on your own. If it's something that you're passionate about, like I know that you and I have published in the past, and are will be publishing again soon. And this was an unfunded study outside the scope of my previous research, and really outside of the scope of your practice. But it was something that we were passionate about, so we generated meaningful data. And there are no, there may be limitations whether or not the author has to have a terminal degree or some type of medical degree, but you can just try. The other approach is to make a connection with industry, and this is a really important collaboration. And this, I think, drives some of the most meaningful research that's going on, where a provider may know their sales rep or may have an idea for a certain drug or device. They should be put in contact with their medical science liaison. And this is where investigator-initiated trials really come to life. So let's say that as a physician, you've got an idea, maybe it's an off-label application of a drug, or it is a novel observation you've made in practice. I'm seeing this outcome that I see is void in the literature. You would liaise with a medical science liaison, so another MD, PharmD, or PhD, and develop that idea together. And that is a very viable and rather streamlined way to begin clinical research. And I think it's also interesting to see young physicians go that route and really start to establish themselves in their therapeutic area, and the long-term downstream ramifications of that are building, industry relationships, and generally that leads to speaking or presenting at conferences or congresses, which in turn drives more collaborations, and that may look like clinical trials, pipeline studies. So that really, it's interesting to, in my line of work, to start to work with MDs that have never done any research but have great ideas, and all of a sudden you see them take, a very research-heavy role with their industry collaborators.
Something I've seen last year when we were at the A4M, you would have researchers look at, I believe from their personal experience, looking at the uric acid and metabolic syndrome. And something that then prompted me to do more research on uric acid, because I thought that's just, allopurinol, gout, whatever, it's just uric acid. You don't really pay too much attention to it. It's just a small, cheap marker. And now I kind of want to look at it in pretty much everyone because of the association between uric acid and metabolic syndrome. And that's because of, obviously someone else going out and observing from their practice as an MD. There was the one presentation about it, and I thought that was very interesting because that's just what they see, and then there's a theory, there's a hypothesis, and then they go on, and eventually it becomes something that may be impactful, and it's something you have to be passionate about, and as long as you kind of go and observe it, and if it's meaningful, you want to publish. I think it's there's nothing wrong with it.
It's a good example of if you notice something anecdotally in your practice, it's great if you share that with the community, especially people with a similar patient population, but it should be presented as that. So it's not like you're presenting, for example, uric acid, don't check a fasting insulin, don't do a CGM, don't check an A1C, just check uric acid. Obviously that's not the case.
Right.
So it's good to present it as, this is something I've noticed. We don't know the significance of this, but it is a useful tool and I've used it. And we certainly share our findings publicly and also amongst ourselves as almost like it reminds me of an academic center when we have people, essentially an interdisciplinary team at Gillett Health, and we share findings amongst each other and use that to apply different topics clinically. A lot of individuals who listen to our podcast or who are interested in our individualized medicine project have lots of different degrees. There's PTs, DCs, NDs, a whole host of different degrees, PAs and NPs, of course, MDs and DOs. And a lot of them are also practicing functional medicine providers. And often we get the question, how do we know what to try to see and what to try to refer on? And it can be a very difficult question to answer, but just keep in mind there's been many different studies, even with MDs and DOs, and MDs and DOs provide a higher quality of care if they're part of an interdisciplinary team. So what I encourage other healthcare providers to do, including MDs and DOs, but especially so if you're applying new scientific topics and you may not have that same degree of background in your training, it's even more important to work with an interdisciplinary team just so that Swiss cheese is as thick as possible, and ideally at the end of it you would have an MD or a DO as the rind.
I think that's a great way to look at it. The more eyes you have crawling the clinical literature or observing what's going on anecdotally with patients and in the lab work and from a pharmacology standpoint, the more successful and the stronger that team is going to be. You know, 4 brains is always going to be better than 1. And I like what you said about always being plugged in with an interdisciplinary team. Because as a nurse practitioner, I kind of get caught up in this where, you know, there's a huge push for independent practice, and I'm not sure that it's fully warranted. You know, I don't have an issue being plugged in with the team. I don't want to be on my own island over here treating patients independently. You know, I like to be plugged in and always have someone that I can go to and say, hey, you know, have you seen this before? Or, you know, hey, what do you think about, you know, this theory? Because I'm always, you know, tinkering. I'm not necessarily thinking, okay, I'm going to treat hypertension, diabetes, lipids, and then anything else I'll refer. You know, there's some people, you know, primary care providers, that they treat the common pathology and then they refer out, and that's an important service. A lot of times primary care does get a bad rap because, you know, they don't know exactly what's going on, but there's just so much pathology now. We know so much more that you have to have specialists that you can refer out to, and knowing when to refer and when not to refer is very important. So I think whenever people who have vastly less, you know, medical education and less clinical experience, for example, a new MD that's completed residency versus a new NP that's completed clinical hours. Some states that's around 600 hours, and then they can be independent. The university that I went to was, I believe, 750 hours of clinicals, and I actually participated in some extra clinical hours because I had really good rapport with my internal medicine physician that was my preceptor at the time. He had been in practice for 30 years, seen lots of great things, so I was always writing things down and stashing away these clinical pearls that would come about whenever we were, you know, going and seeing the patients, and taking a very autonomous role but also having backup at the same time. And I have heard some, you know, more unfortunate cases where the NPs are essentially shadowing during their clinical hours. They're not doing the differential or the critical thinking, and then a lot of times they get into practice, they're overwhelmed, they think it's not for them, so then they'll go back and end up working as an RN, still having the NP degree, but just it wasn't for them, and it's not for everybody. So it's important to realize it is a very autonomous role if you want to pursue that and complete it. But even though you're functioning autonomously, you want to be plugged in with other medical professionals, just like any healthcare team should be.
So what did your education look like? Can you kind of talk about your route to being an NP and how how those classes differed from what Ben and I spoke about, and sort of, you know, where you're at now? Another question would be, how does an NP differ from a DNP, from a CRNA, and, you know, from an MSN?
Yeah, you know, I went right out of high school into nursing school. Usually there's about a year of the biologies and the chemistries and certain levels of math and communications classes, your prerequisites you would take. I was in a fortunate place where my mother advised me and was working for a local community college where I was able to get those done early, do those in high school, and then the summer after high school, and then go right into LPN program. So I had my LPN license at age 19 and started working part-time on the weekends as a nurse while completing my associate degree of nursing, which is what most of your RNs are, unless they attend a 4-year program where they're getting a BSN degree, which is a Bachelor's of Science in Nursing. So I got out and started working as a registered nurse, and within a year I moved to that float pool position that I referenced earlier because I didn't want to do the same thing over and over again. I liked the variety. It helped me to stay engaged and continue learning. And then the path for me to a master's degree, which is what I currently have, involved first getting the bachelor's degree. So that was a lot of theory, a little bit of statistics, epidemiology, informatics, so looking at how clinical decision-making tools are created, things like that. And then at that point, once you have that BSN, there's, I believe, 4 or 5 branches you can go into. There's a family nurse practitioner, you have a acute care nurse practitioner, And the family nurse practitioner, which is what I am, functions outside of the inpatient model. So they're working at your urgent cares, your family medicine practices. Acute care is really limited in their scope. They could probably function in an urgent care, but they are only trained to see adult patients, and typically those are going to be the ones that are in the hospital working alongside the hospitalists. You have the nurse educators, which are people that want to go back and pursue teaching, becoming a professor or assistant professor. You have nurse midwives. And then I believe there's even a terminal, like a master's degree in informatics for people that really just want to look at the numbers and develop new tools around that. So that's the general branch decision-making point. And for myself, the F&P offered the most variety. So if you're an F&P, you can always go back and do acute care. You can always go back and do I believe it's like a 1-year emergency medicine course, clinical fellowship. I don't think it's appropriate necessarily to call it a fellowship, although some places are starting to do that. So a fellowship is typically much more involved if you're looking at the time difference. So I said, well, this has a lot of variety, so I'll do this. And I did have the intention to primarily treat adult patients, because the process of going through a differential on an adult patient is very rational, whereas a lot of times in children there's a strong psychosomatic component to the pathology, which I find to be a bit puzzling and confusing. I'm more in the rational box when I like to problem solve. So I had the intention to primarily treat adult patients, and the coursework is about a 30-month process, 2.5 years after the bachelor's degree. So there are some programs that are faster or slower. It really depends on the time you want to set aside and do that. Usually people will either quit working to pursue the program, or at least cut back on their hours and work part-time, which is what I did. I worked typically a shift or two per week while I was doing my MSN program, because I really wanted to dive in. I didn't want to just coast through, because the programs have good content, but you get out of it what you put into it. So lots of paper writing, lots of case studies, lots of developing the treatment plans. And this is before you are actually treating patients in person. So I would say that's similar to medical school when you're looking at the courses like your A&P, advanced A&P, pharmacology, advanced pharmacology, looking at medical statistics and epidemiology, and all these sorts of things. And you go back through it, it's less of a speed run than it was in the ADN program. The associate degree of nursing program, you're essentially 8 weeks, here you go, this is this body system, this is this body system, and you just speed run through psychology, cardiology, your respiratory system, just very quickly. You go through most of the common disease processes. Now, you don't necessarily go through every condition that you're going to ever see, or that you could ever potentially see, but you know your red flag signs, when to refer, how to treat common things, and then you go into the clinical environment and you start putting all the pieces together. So, in my opinion, I think that should be done under a MD or DO. Some programs in some states will allow you to do your clinicals under an NP, and I think that the quality is going to be more variable from NP to NP than from a MD to an MD. Because medical school and the residency, from what I understand, is very intense and demanding. So you're selecting for the most intelligent people to get in, and then also the most resilient people to follow through and complete that 4 years of medical school and the residency. So that's kind of how they compare in my mind, just a very simple way. But as far as the actual getting to where I am now, I think that having a great internal medicine MD was a great tool for me. I've kind of taken a bit of every practice that I've been in, all the best parts there, all the best tips, tricks, all the best clinical findings, for example, physical exam tricks, things like that, and incorporated that into the practice that I have now, and I continue to do so. Every time I meet a new interesting clinician, or a clinician that says something that I'm not familiar with, I always want to pick their brain a little bit and then see, okay, is this something that is evidence-based? I think the functional medicine world is a great point of this. Some people will say, if you hold something close to you and you feel good, that's a positive aura. It's far away. I don't want to discourage anybody's beliefs, but for me, that's not something that I incorporate into my practice. I'm more, like I said, very hyper rational and data driven. And what I believe I practice is like evidence-based integrated medicine. So you take your patient, and the first thing you want to do is true preventive medicine. You go down your checklist. What do you want to prevent from happening? And then your patients, you say, okay, what are your specific goals? How do you what are your areas for improvement? Do you feel like you want more energy? Do you want to lose weight? Those are probably the two biggest things that I hear people talk about. And then you build an individualized plan to get there. For some people, they don't want to take medications, and that's fine. You can use supplementation. Targeted supplementation is very important. I don't have take these 10 supplements stacked for every individual patient, but you take it a very nuanced way and say, okay, if we're trying to increase, dopamine signaling is a very popular topic, something that people are commonly asking us. And we'll say, okay, well, we can do this. But that's kind of how I think of it, is the smart prescribing, smart supplementation, and then pursuing what a individual wants to pursue. We have the flexibility to do that with our individualized medicine program.